Hello there, my name is Christa Metzelaars, or Christa Paap. This is my husband, Jason. He's going to be acting as my patient today for my head-to-toe assessment for nursing 513.
Come in.
Hello there.
Hi.
How are you?
Good.
Good. My name is Christa. I'm a nurse practitioner student. Do you mind if I do a head-to-toe assessment on you today?
Yes, you can.
Okay. So as I enter the room, I first start by making an observation on Jason's general appearance and affect. I would say that Jason is young, he's healthy appearing, he's well-groomed, cheerful, and cooperative. So then I would move on to assessing Jason's mental status. Jason, can you tell me your full name?
Jason Metzelaars.
And do you know where you are today?
I'm sitting on my couch in Charleston, Illinois.
Yes, and do you know why you're here?
To be your student to help you out.
Yes, and do you know what the date is today?
Yes, it's July 31st of 2014.
Perfect. So I would say that Jason is alert, he's well-groomed, he's cheerful, he's cooperative. I would say that his speech is fluent, his words are clear, he's easy to understand. I would say that his thought processes are coherent, he has good insight, and I would say that he's oriented to person, place, time, and current situation. So then I would move on with my assessment of the head. I would first start by inspecting his face. I want to note the patient's facial expressions as well as the contour of his face. I want to observe for any asymmetry, any involuntary movements, any edema, as well as any masses that may be present. And I don't see any of those. So then I would move on to inspecting the hair. I want to note its quantity, its distribution, as well as its texture, and I want to note for any patterns of hair loss, and I don't see any of those things. So then I would move on to the inspection of the head. I want to observe the general size and contour of the skull. I want to note for any deformities, any depressions, any lumps, any areas of tenderness, as well as note for any irregularities, especially near the suture lines. And I don't see any of those things. So then I would move on to the palpation of the scalp. As I start, I just want to double check myself on the texture and the distribution of the hair again, and check myself on any little areas of hair loss that I may have missed on my general inspection. I don't see any of those. So then I'll start and I'll just part the hair in several different areas here all over the scalp. I want to check for any lesions, any open areas. I want to note for any masses, any nevi, anything that could be concerning. And I don't see any of those things. So then I want to do a little deeper palpation. I want to check for any depression, any mushy areas. I want to know any masses, bumps, lesions, anything that I could have missed just on my general inspection. And I don't see any of those things. So then I would move on to the eyes. I first just start by just observing or inspecting the position and the alignment of the eyes. I want to make sure that Jason's eyes are aligned with the tips of his ears, and they are both symmetrical. And so then I would move on to the eyelids. I want to note the position of the lids in relation to the eyeballs themselves. I want to inspect for any edema. I want to inspect the color of the lids. I want to check for any lesions. I also want to check the condition and the direction of the eyelashes, and Jason's eyelashes look good. Jason, could you close your eyes for me? Good. And by that I'm just checking the adequacy of his eyelid closure, and there's no difficulty there. So then I'll move on to test Jason's visual acuity. This is assessing for cranial nerve number 2. I will do this first by the Snellen chart. This is testing his central vision for far away. So Jason, if you could stand up for me. I have a Snellen chart to the wall, to that far wall. So I'll place Jason about 20 feet from that. And Jason, with both eyes, can you read the lowest line possible for me?
Yes, I can. It's D-E-F-P-O-T-E-C.
Good. And if you could cover your left eye for me. And with your right eye, can you read the lowest line possible?
Yes, it's F-E-L-O-P-Z-D.
Good. And if you could read the next line lower for me.
D-E-F-P-O-T-E-C.
Good. And if you could uncover that left eye, give yourself a second to adjust here. Whenever you're ready, if you can cover your right eye and read it with your left eye.
Okay. It's F-E-L-O-P-Z-D.
Good. And can you read the next line lower?
D-E-F-P-O-T-E-C.
Good. If you could go ahead and take this seat back down for me. So Jason's visual acuity is 20/20 in bilateral eyes, as well as in the right eye and the left eye based on the Snellen chart. So then I'm going to check Jason's near vision. I do this using a Rosenbaum chart. This isn't an actual Rosenbaum chart as far as the size and everything goes. It's just when I print it off, but it'll work for today. So I'll have Jason hold it about 14 inches from his face. There you go.
Sorry.
And with both eyes, if you can read the lowest line there possible for me.
Yeah, it's 63925.
Good. And if you could cover one of your eyes for me.
Okay.
And whenever you're ready, read it with your right eye.
Alright, it's 63925.
Good. And uncover that eye. Give yourself a second here. Whenever you're ready, if you could cover your right eye and read it with your left.
Alright, give me a second here. I think it's 63925.
Yes, that's good. So Jason's near vision is good too based on the Rosenbaum chart. So again, the Rosenbaum and Snellen were assessing his visual acuity, and that it was assessing cranial nerve too. So then we move on to check Jason's visual fields. This is assessing cranial nerves 3, 4, and 6. I'm going to do this first by the static finger wiggle test. So Jason, if you could stand up for me here. And I'm going to place myself about 2 feet away from Jason. And Jason, whenever you can see my fingers in your visual field, if you could let me know.
Right there.
Good. And then I'm going to check Jason's ocular movements. This is assessing cranial nerves 3, 4, and 6 as well. I'm going to do this by the figure 8 test. So Jason, if you could hold your head still and just follow my finger here with your eyes only. Good, so no problems with that. Again, both of those were assessing for cranial nerves 3, 4, and 6, so I would say that those are intact on Jason. So then I move on to inspecting the conjunctiva, the sclera, the cornea, as well as the orbital area. So Jason, if you could just look up for me here. Good. Good. As far as the orbital area, I just want to assess for any edema, any masses or lesions in that area, and I don't see any of those. And then as I'm inspecting the conjunctiva and the sclera, as I pull down the lid there, I'm exposing the sclera and the conjunctiva. I just want to note for any vascular patterns against the scleral background there. I want to note for any nodules or any swelling there, and I didn't note any of those. And then to do the cornea, I would use oblique lighting, and I would just want to check for any opacities that may be visible through the pupils there. And so then I'm going to move on to test the pupillary reaction to light. This is assessing cranial nerves 3, 4, and 6. So Jason, if you could just look straight ahead for me. First I'm going to start by doing the left eye. Good. Now the right eye. Good. And then Jason, if you could just follow this pin here. Good. So I would say that Jason's pupils are perla. They are equally round, reactive to light, and accommodation. And then next I will do the cover-uncover test. This is, again, just checking the ocular movements there. So I would start by covering his right eye. And Jason, if you could just look straight ahead with both eyes here. And I'm going to shine the light in the left eye. Good. And I did not see any extra movements there. And again, I'm going to repeat it on the other side. Good. So again, those were assessing cranial nerves 3, 4, and 6 with the pupillary reactions to light, the cover and uncover test. So then I'm going to move on to the ophthalmoscope. If I had one, I would use it. I don't, so I'm just going to use a pen light just to say I did it. But with this, I'm going to check the red reflex in both eyes. So I will stand approximately about 15 inches from the patient, and I will just check for the red reflex. If I have the ophthalmoscope, I would check for that. And that is just assessing cranial nerve 2. So then I move on to the ears. First, I just want to inspect and palpate the external ear on both sides. I just want to check for symmetry. Again, I want to note for any masses, lesions, any open areas, any areas of tenderness there with that, and I don't see any of those. So then I would move on to the otoscope exam. I don't have an otoscope, so I'll just use the pen light. So first I'll start with Jason's left ear here. Good, and I will just note that the canal is not erythematous. There's no masses or lesions within the canal itself. The TM is pink and gray in color. There's no air fluid levels noted. I would say that the cone of light is situated around 7 o'clock, and that his bony landmarks are well visualized and appropriate. And I would move over to the right ear here. And again, I would say the same thing about the canal. There's no erythematous noted. There's no open masses or lesions noted within the canal itself. The TM is pinkish gray in color. The cone of light is well visualized around 5 o'clock. as well as the bony landmarks. They are well visualized and appropriately situated within the ear. So then I move on to assess cranial nerve 8. I do this by the Weber and Rene test. So this first one is the Weber test. It tests for lateralization. So Jason, if you could please tell me whether you hear this in the left ear, the right ear, or both ears.
Okay. Both.
Good. So no problems with lateralization. And then the Rene test will test for air conduction versus bone conduction. So I'll strike this. I'll place it on Jason's mastoid. And Jason, if you could tell me when you can no longer hear it.
Okay.
And tell me when you can no longer hear it.
Okay.
Good. And then I will do the same on this ear. Tell me when you can no longer hear it.
Okay. Okay.
Good. So as with Jason and any normal healthy person, air conduction, of course, is going to be greater than bone conduction. Again, that was assessing cranial nerves 8 for both the Weber and the Rene test. So then I move on to the nose. I'm first going to start by palpating the frontal and maxillary sinuses. I want to note for any edema, any swelling, any tenderness within that area. And I don't know any of those things. So then I move on to inspecting the nasal septum and the turbinates. So I just want to check the nasal septum there. I want to check for any deviation. I want to check the turbinates. I want to make sure that there's no obstruction, that there's no asymmetry, there's no significant redness or swelling within there, and there's not. So then I will move on to assess Jason's sense of smell, which is cranial nerve 1. So Jason, if you could close your eyes here for me, and if you could tell me what that smells like.
Coffee.
Good. So I would say that cranial nerve 1 is intact with the sense of smell. And Jason, could you wrinkle your forehead up for me? Good. That's assessing cranial nerve 7, and that is intact. And then I will move on to palpating the masseter. Can you clench your teeth for me here? Good. And can you open your jaw? Good. Close it. And then side to side. Good. So with Jason, he has a history of TMJ, so you can definitely, I don't know if you could hear it on the video or not. I could hear it when I was here, and I could also feel the clicking there in the masseter. But on a normal person, a little bit of clicking is okay, but not as much as Jason has. I would also want to note for any swelling or any area of tenderness within there. And by doing that, I was assessing cranial nerve 5. So then, Jason, can you please puff your cheeks out? Smile for me. Good. I would say cranial nerve 7 is intact. And then, Jason, can you please stick your tongue out? Say ah. Ah. Wiggle it side to side. Good. Cranial nerves 4, 5, and 7 are also intact. So then I'll move on to inspecting Jason's lips, gums, teeth, tongue, buccal mucosa, as well as the pharynx. So first I want to start with just assessing his lips. I want to observe for the general color, as well as the moisture. I want to note for any lumps, ulcers, cracking, any scaliness of the lips, and I don't see any of those. So then also tongue depressor would help with this assessment. But if you could open your mouth for me. Good, I'm going to start by assessing his tongue. I want to make sure there's no areas of scaliness, there's no open lesions, sores, masses, anything like that. I want to make sure the tongue is symmetrical. And then also I want to move on to his gums. I want to make sure that there's no significant areas of redness, bleeding, swelling, anything abnormal there. I want to check out his teeth while I'm doing this assessment. Jason has good dentition. I don't see any cracked teeth or any problems there. Say ah. I want to observe the soft palate as well as the uvula. I want to check that the uvula is midline. I want to check the tonsils, make sure that there's no exudate noted, that there's no tonsillar enlargement, and I don't see any of those things. So then I will move on to the neck. First we're going to start out with the range of motion of the neck. Jason, if you could touch your chin to your chest, please. Good, that is assessing the flexion of the neck. And if you could look up at the ceiling, good, that's assessing extension, no problems there. And then if you could look over your right shoulder, good. Now your left shoulder, good. That is assessing the rotation of the neck. And then if you could touch one ear to your shoulder, good, and now the other, good. And that's the lateral bending of the neck, and Jason has no problems there with the range of motion of his neck. Next we're going to assess the strength of the neck. If you could push against my hands, yep, and that. Good. So with that I'm assessing cranial nerve 11, and there's no issues there. Jason, can you shrug your shoulders for me? Good. And then push up with your shoulders. Good. Again, that's also assessing cranial nerve 11, and there's no difficulty with that. So then I'm going to move on to palpating his cervical nodes. Also, I'm going to assess the trachea and also palpate the thyroid. So I'm going to start by just palpating his cervical nodes here. I want to check for any swelling. I want to check for any areas of tenderness. Good, no problems there. Can you lift your chin for me? I'm going to check Jason's trachea. I just want to make sure that it's midline, not deviated to one side or the other, and it's not. And then also, I want to palpate Jason's thyroid. Can you swallow for me? Good. I just want to make sure that there's no palpable nodules, no areas of tenderness within Jason's thyroid, and there's not. So now we're moving on to the assessment of the respiratory system. So first I'm going to start by inspecting. So Jason, if you could take off your shirt for this portion of it. I'm just going to start by inspecting the shape, the symmetry, the color of the skin, his thoracic shape and condition, and also the EP diameter. So just by looking at him, I can tell that he's symmetric. I can tell that there's no cyanosis. His skin color is appropriate to the rest of the skin on his body. His EP diameter is greater than his thoracic diameter, which is an appropriate finding in a healthy adult. So then I would move on to the inspection of the respiratory rate, which I would say that Jason's probably breathing like 14 to 16 times per minute, which is good. I would say that his respirations, they're regular, they're non-labored, and he appears to be in no acute respiratory distress. I don't see any nasal flaring, there's no grunting, there's no use of accessory muscles. He's not dyspneic or tachypnic, so that is good. And then I would move on to the palpating his thoracic expansion. So Jason, if you could turn a little bit for me here. And I'm just going to be placing my thumbs down here. And if you could take a nice deep breath in for me. Good. And I know equal and symmetric expansion with that. So then I will move on to percussion. I'm going to percuss over the anterior and posterior lung fields. And as I'm percussing, I'm just going to be comparing from one side to the other. Good. And then here, posterior side here. Okay, good. So as I was percussing, I heard resonance, which is the normal sound that you would expect for the chest. I did note some dullness over the left side where the heart is, and again, that's a normal finding. The intensity it's pretty loud whenever I was percussing. The pitch is a low pitch, and it has a longer duration in sound. So, and that was both for the anterior and posterior chest. So then I would move on to percussing and measuring the diaphragmatic excursion. So Jason, I'm going to be coming around to your backside here.
Okay.
And I'm just going to percuss here until I can hear some dullness. Okay? And then Jason, I'll have you take a breath in. Good. Again for this side. Okay, and take a nice deep breath in for me. Good. Exhale. So I would say that Jason's diaphragmatic excursion was around 5 centimeters, which is normal. 3 to 5 is normal in a healthy adult. So then I'm going to move on to auscultating both the anterior and posterior lung fields.
Are you okay?
You can take some nice deep breaths. Listen to it outside here. Again, some nice deep breaths. Good. So again, with auscultation, I'm comparing one side to the other, making sure that there's symmetrical breath sounds and that they're equal throughout. In each lung field, I'm going to auscultate for a full inhalation and then expiration as well. I'm going to note for any wheezing, any crackles, any coarse lung sounds, which Jason's lung sounds are clear throughout, which is what I would expect for a normal, healthy 26-year-old male. So now we're going to move on to the cardiovascular assessment, and this is probably going to be the worst cardiovascular assessment I ever have or ever will do on a patient, just based on the simple fact that it's in our living room on our couch. But we're going to try to do the best that we can, and if I can't physically do it, I will at least walk my way through it. So, Jason, if you could go ahead and lay back for me. In my perfect world, I would have Jason on an exam table, and I would have the head of the bed elevated to approximately 30 degrees here for my cardiovascular assessment. But anyway, so to begin with, I would just inspect the precordium for any palpations. Good. And then I would move on to inspecting and measuring the JVD, and this is one that it would not be an accurate finding at all if I even tried to do it. But in order to measure the JVD, I would have the patient comfortable. I would have the head of the bed at about 30 degrees. I would first have the patient turn away from me, and I would identify the highest point of pulsation there on the right jugular vein. From that point, I would extend a long ruler card object of some sort horizontally, and then that would be met with a centimeter ruler that is vertical on the sternal angle there, and wherever it matches up, that would be my JVD. In a normal adult, the JVD is about 4 centimeters or less. So that is how I would do that. And then in order, I would move on to palpating for the PMI. So I'm going to go ahead and try to do that on Jason here. Good. So as I'm palpating for the PMI, I found it on the 4th or 5th interspace there. That's the normal, usual location for it, and it would be mid-clavicular line. And then I would describe the amplitude as brisk and tapping, and then the duration would be about 2/3 of systole, which is a normal finding for the PMI. And then next I would go on to palpating and auscultating the carotids. So Jason, if you could just go ahead and turn that way. First I'm going to palpate your carotid arteries here. Good. And then if you could turn this way for me. Good. Now I'm just going to take a listen. Okay. Good. So as I'm auscultating both carotids, I just want to make sure that I'm listening for any bruise or anything of that sort, and I didn't hear any of those. So then I'll go on to auscultating each site for S1 and S2. So I'm going to go ahead and do that. I will start in the aortic area. And then I'll move to the pulmonic. And then I'll move to the right ventricular. And then I'll move to the left ventricular. Good. And S1 and S2 can both be heard in all areas, so that is good. And then in order to assess for S3 or S4, I would have Jason turn to his left side. I would have him take a breath and breathe it out, and once he exhales completely, I would have him hold his breath while I listen there. And then in order to assess for splitting, I would have him still turn to his left side there, and I would listen in between the 2nd and 3rd interspaces. I would have him breathe softly and then a little bit more increasingly deeper as I listen. And that should give me a good audible means of hearing for any S3 or S4 or any splitting. Now we're going to move on to the assessment of the abdomen. So my assessment will first start with inspection. I'm just going to inspect the overall contour, the skin, the symmetry, and I'm also going to inspect for any hernias in the abdominal area, and I don't see any of those. I'm going to assess for Turner sign, which is bruising over the flank. So Jason, could you do it that way for me? Good, and then roll this way. Good, and then I'm also going to assess for Pullen sign, which is bruising around the umbilicus, and I don't know either one of those. So then I'll move on to auscultating. I'm going to start by auscultating over the aorta. Jason, if you could put your arms to your side there for me and just try to relax. Good, and then I'm going to move to the renal arteries. And then I'm going to move down to the iliac arteries, and as I'm listening, I'm just listening for any bruise. Good, and I don't hear any. Then I'm going to continue on with auscultating in all 4 quadrants. And Jason has active bowel sounds in all 4 quadrants, but if there's any suspicion, of there being an absence in bowel sounds in any of the quadrants, I would need to listen for a full 3 minutes just to accurately determine that. So then I'll move on to percussion. I'm going to do a general percussion of the abdomen. And so I note that I hear tympany, which is a normal sound for percussion, just based on all the gas that's there in the gastrointestinal tract. So then I would move on to percussing for liver size. In order to do this, I'm going to start at a level just below the umbilicus. There in the right lower quadrant, I'm going to percuss upward toward the liver. I'm going to identify that lower liver border by dullness, and that should be located along the midclavicular line. So then I'm going to mark that area, and then I'm going to then start around the nipple line, and I'm going to percuss lower until I hit the border there of dullness. So I'm going to go ahead and do that. Good, and I would just measure the distance between those 2 points, and that will give me the vertical span of the liver. And so then I would go on and I would percuss for the location of the spleen. So in order to do this, I'm going to start percussing at the left lower anterior chest wall, roughly from the border of cardiac dullness, and that should be around the 6th rib, to the anterior axillary line and down the costal margin. I'm going to go ahead and do that. And so then from there, I'm going to start palpation. So I'm going to start with a light palpation of the abdomen. I'm going to note for any tenderness, any areas of rigidity. Good. Then I'm going to move on to a deeper palpation. Again, I'm going to feel for any masses, any areas that are tender to the patient. Good. And so then from there, I'm going to palpate for the liver. Can you take a deep breath in? Good. So on a normal healthy individual, you should be able to feel the liver about 3 centimeters below there. And then I'm going to make sure that there's no spleen enlargement. Just relax back in the camera. There you go. And take a nice deep breath in. Yeah. Good, and I don't feel any spleen enlargement. So that pretty much includes that. There are a few additional exams that you can do. One is to check for superficial abdominal reflexes, so I'll do that. Good. And those are present. And then also I would definitely want to check for any rebound tenderness. So I probably would have done that as I was palpating the abdomen if I noticed any right lower quadrant pain, but I would go ahead and do that again. And I don't note any signs of pain upon palpation. So then I would move on to the iliopsis muscle test. So Jason, if you could please just raise your right leg against my hand. There. Did that cause any pain?
No.
Okay, so that's the iliopsis. And then I would also check the obturator muscle test. So Jason, I'm just going to fix your hip here. Any pain? Nope. Okay. So that is negative as well. And then I will move on to palpating for the inguinal nodes as well as the femoral pulses. I'm just going to check for any swelling, any areas of tenderness there in the inguinal nodes, and then I'm just going to check for the femoral pulses here, make sure that they're strong and equal. And they are. Now we're going to move on to the neurological exam. So Jason, you can stand up here for me and you can put your shirt back on if you like. Okay, so first I'm going to start by assessing your gait. If you could just stand over here for me and walk towards the wall over that way. Good, and then as you come back, if you could just do the heel to toe walk for me. Good, you can go ahead and take a seat back down. So I would say that Jason's gait is steady, it's without difficulty, no weakness noted or anything like that. So then I would assess his coordination. I would want to do this by rapid alternating movements. So Jason, if you can take your hands and just alternate back and forth from your hands to the backs of your hands like that, as fast as you can on your thighs. Good, and Jason is able to do that without any difficulty. So the next I'll test the Romberg test. Jason, if you could stand up for me here, put your feet together, and stretch your arms out for me at a 90-degree angle, and close your eyes. So with this, I'm just making sure that Jason's balance is there, and it is. So you can go ahead and take a seat back down. And now I'm going to test the nose to finger test. So Jason, if you can just take one of your fingers, touch my finger, and then back to your nose, and then keep going as fast as you can. Good. So no problems with that. So then next I'm going to move on to fine motor skills. Jason, if you could just pick up this paper clip for me. Good, and he is able to grasp that paper clip and pick it up without any difficulty there. So then next I'm going to move to proprioception. And so Jason, I'm just going to take your finger here, and if you can close your eyes for me and tell me which direction I'm moving your finger. This is up, and this is down.
Up, up, down.
Good, and I would assess this on all four sides of the body.
Up, down.
Good. And now your foot.
Up, down, down, up.
Good. So Jason does not have any difficulty with that. Next I'm going to move on to his reflexes. So first I'm going to start with the bicep reflex. Stretch your arm here for me.
Okay.
Good. And the same on this side.
Okay.
And as I'm assessing reflexes, I make sure to do it on both sides there, and you can see the reflex there. So then after the bicep, I'm going to try the tricep. This one's hard on Jason. I've been practicing and I can never get it, so bear with me. Just relax your arm here for me, Jason. There, I got it, first time. Then I'm going to move over to this side. Just relax your arm there for me. I think that was a fake one, but
No,
we'll go with it. Oh,
it
okay.
moved.
Okay, so then I'm going to go on to the brachioradialis reflex. So just relax your arm down there for me. Good. Just relax your arm back here on your leg.
Okay.
Good. So then I'm going to move on to the patellar reflex, and it's going to be hard because Jason's tall and has long legs, and our couches are very, very high. But if I had him on the exam table, I would have his legs dangling over. And I would try to get him to relax as much as possible. Do you think if you scoot back on the couch it might look better? Probably not. Just relax your legs down here for me, Jason. Was that fake?
No, you hit it. She did good. I promise.
Okay, so then I'm going to move over to this side. Was that fake?
No, I
Okay,
swear.
I guess I got the patellar reflexes.
She
so
got
then
it.
I would move on to the Achilles. So I'm just going to take your leg up here, Jason. I'm just going to relax it here. There. So then I'm going to move on to test Jason's sensory function. So Jason, just with this paper clip, I'm going to need you to tell me whether I'm touching you with the dull side or the sharp side. If you could close your eyes for me here.
Okay. That's dull. That's sharp. That's sharp. That's dull. That's dull. That's sharp. Sharp. It's dull.
Good, so that Jason doesn't have any difficulty there with any sensory function. And then also you could use the tuning fork over the joint. Can you feel that?
Yes, I can.
And that?
Yes, I can.
Okay. Good. And then next, actually that's it for the neurological exam. I have already assessed all of his cranial nerves whenever I did the assessment of his head and neck. So those are already completed. Now we're going to move on to the assessment of the musculoskeletal system. So first we're going to start by doing the 6 range of motion movements of the shoulder. So Jason, if you could stand up here for me. First we're going to start with flexion. So Jason, if you could raise your arm in front of you and overhead, one at a time. There, and now the other one. Good, so no problems with flexion. Now we're going to move on to extension. So Jason, if you could just take it and move your arm behind you there. Yep, and now the other one. Good, so no problems with extension. Next we're going to do abduction. So Jason, if you could raise your hands out to the side and then overhead. Good, and now the other one. Don't mind our ceiling fan in the way. So no problems with abduction. Next we're going to move on to adduction. So Jason, if you could cross your arm across your chest. Again, this is adduction. Good, and no difficulty with either one of those. Next we're going to do internal rotation. So if you could take and reach up towards your shoulder blade, and now with the other one. Good, that was internal rotation. Now we're going to do external rotation. Yep, you reach down and then on this side. With that shoulder blade. Good, so no problems with either one, internal or external rotation. Next we're going to move on to the range of motion exercises or movements of the elbow. So Jason, if you could just take and bend your elbow for me. And as Jason bends his elbow, that is flexion, and then as he straightens his elbow, that is extension. And again, flexion and extension. So then we're going to move on to pronation and supination. So Jason, if you could hold your hands out like this. So this is pronation, and then as he moves his hands over, that's supination. And you would just check that. And he doesn't have any difficulty doing that. So then next we're going to move on to the crossover test. So with this one, I am just going to take and adduct Jason's arm across his chest as I'm palpating the acromioclavicular joint, and I'm going to palpate for any swelling and then ask Jason about any tenderness. Anything there?
No.
Good. And then I'll do the same on this side.
Nope.
With that? Good. And I didn't appreciate any swelling there in the acromioclavicular joint. So then next we will move on to the drop arm test. So Jason, if you could take your arms out at a 90-degree angle, and if you could slowly lower them for me. Good, so Jason didn't have any difficulty doing that. And somebody that had a rotator cuff injury, they would not be able to slowly lower their arms. They would have a drop in one arm over the other, whichever the affected side it is. So then next we'll move on to the Nearest test. So with the Nearest test, I'm going to apply pressure to Jason's scapula as he raises his arm. Can you scoot forward just a little bit for me? Good, so I'm applying pressure as I'm raising his arm. Any pain with that?
No.
Good. And again on this side. With that.
No.
Good. So again, that was the nearest test. So then now we're going to do the Hawkins test. So for the Hawkins test, I'm going to take in and place Jason's arm and shoulder here at a 90-degree angle. I'm going to internally rotate, and then I am going to check for any tenderness or swelling here in the coracoid ligament. And any problems there?
No.
Good. And then I'm going to do the same on this arm.
Okay.
Turn over. And any pain or swelling there?
No.
Good. And so then we are going to move on to the Finkelstein's test. So Jason, if you can take and grasp your thumb for me here and just move your wrist down for me. Any pain or difficulty doing that?
No.
And can you do it with the other one?
Yes.
Good. So then next we're going to move on to the Tenel's test here. So I'm just going to take and I'm going to tap right here. Do you feel any numbness or any pain as I'm doing that?
No.
Good. Any pain or numbness there?
Nope.
Good. Can you scoot back a little bit so you're in the camera there? And then if you could go ahead and do the Fallon's test here for me, if you could push your arms against each other there, or your hands, excuse me, for about 60 seconds. And do you have any numbness or pain whenever you do that?
No.
Okay. People who have carpal tunnel syndrome will experience some numbness and also some pain in their wrist with both the Tenel's and the Fallon's sign. Next, we're going to move on to the bulge sign. So, Jason, if you could lay down on the couch here. And so for the bulge sign, I'm going to have Jason's legs extended. I'm going to place my left hand above the knee. I'm going to apply some pressure to the suprapatellar pouch and kind of displace or milk that fluid downward. And as I'm doing that, I'm going to stroke downward on the medial aspect of the knee and apply pressure and force the fluid to the lateral area as I'm tapping. Stand your leg there for me. This side. Good. And he is negative for a bulge sign. Next, we're going to move on to the anterior and posterior drawer test. So for the interior drawer test, I'm going to have Jason lay supine with his hips flexed and his knees flexed to about a 90-degree angle and have his feet resting on the table. It's kind of hard here because the couch is so soft, but on an exam table it would be a harder surface for him to lay his feet flat on. I would then cup my hands around the knee with my thumbs on the medial and lateral joint lines, and I would have my fingers on the medial and lateral insertions of the hamstrings. And then I would slowly draw the tibia forward and observe if it slides forward like a drawer from under the femur. And the anterior is negative, so then I would have Jason position the same way for the posterior. I would just push it backwards to see if there is any backwards movement. Good. And Jason has a lot of bony prominence there in his knees. He had Osgood-Schlatters as a child and still has some bony prominence there, so it's kind of hard to tell, but from what I could tell, that was negative for both the anterior and the posterior drawer test. So then I'm going to move on and I'm going to test for the McMurray test. So with this, I'm going to have Jason remaining laying in the supine position. I am going to take and grasp the heel and flex his knee, and then with my other hand I'm going to cup over the knee joint with my fingers and thumb along the medial joint. I'm then going to externally rotate and extend the lower leg. Any problems with that?
No.
Good, and then I would do the same on the other leg. It's hard because of how the couch is. So that was the McMurray test, and then I would move on to the Lockman test. So for the Lockman test, I will place the knee in about a 15-degree flexion and external rotation. I will grasp the distal femur on the lateral side with one hand, and then on the proximal tibia on the medial side with the other. With the thumb of my tibial hand, I will simultaneously pull the tibia forward and the femur back, and I will estimate the degree of forward extrusion there. So no problems doing the Lockman's test. So then I would move on to the range of motion movements of the spine. So Jason, if you can stand up here for me. Good, and I will have you first bend forward and try to touch your toes. So this is flexion of the spine. Good, and then I'm going to have you lean backwards. Good, and that's extension of the spine. And then I will have you rotate from one side to the other. Good, so that's rotation of the spine. And then I will have you bend from one side to the other from your waist. Good, so that is lateral bending. So I think that concludes it for my head to toe assessment. Thank you for bearing with me in our not so great environment to do an assessment, but I think it worked and hopefully I'm not forgetting anything. So thank you, have a good day.